So when should we decide to stop the opioid therapy? Three guiding principles include the following. It's not having any pain relief. It's actually causing major side effects that doesn't allow you to switch up the dose or even rotate to another one. Or third is that they have no change in their function, even using reasonable doses of the medication. And if those goals aren't changing, or in fact, if you detect misuse of the medication, or they're not following in compliance of the way you're dosing it, there needs to be tighter conditions around its use to keep it safe, or that we may have to discontinue it altogether. So how do we practically taper opioids? It really begins with an honest conversation with the patient where the opioids aren't making a difference on their function, or in fact making other aspects of their life worse, and that may be mood, sleep, and bowel function, cognitive function. Lastly, if a patient is having problems using it properly or using it safely, again, the honest discussion to say that this is not the appropriate therapy needs to be had. During that discussion, though, just an open discussion around how to do this safely includes doing it slowly, helping them know what that dosing schedule is going to look like and how frequent you're going to be following them up. Lastly, just to reassure them that they're not going to go through withdrawal symptoms if we go down a very controlled and measured time of tapering. So it's just really important to reassure them. At the same time, they need to be aware of what those possible withdrawal symptoms may be. That includes increased pain, so it kind of sets expectations and they're not feeling panicky around loss of a medication. It would maybe affect their bowel function to have increased stool movement or even loose stools. There can be restlessness, disturbed sleep. All of those things would be normal, and therefore if they feel that, they should report that to you and we can slow that taper down. Sometimes we might choose to add a medication like clonidine or Lyrica just to make that period of tapering a lot easier for the patient. So the key learning points from today's discussion is the following. The National Opioid Use Guidelines were launched in May 2010 to help support all of us to make opioid prescribing safer, easier, and more effective for patients in general. The consideration for using long-term opioid therapy has a lot of different factors, but once we are determining that this is a helpful part of the multimodal approach to pain, then there are these guidelines that exist to help us screen for those who are a bit more vulnerable in using these opioids and having side effects, and then guiding us into how to do a trial and taper where necessary. Then lastly, I really just want to emphasize that the chronic non-cancer pain syndromes do respond to opioids where appropriate, but really it's only one aspect of a multimodal approach to managing pain, and importantly, the pain-related disability. So this slide entitled Opioid Tapering Protocol is pretty specific on how to taper the opioids. Usually the guiding principle is about 10% reduction every 1 week up to every 4 weeks for a very slow taper. And by doing that, you actually really reduce the amount of withdrawal type symptoms that a patient can experience. Where appropriate, the dose should be held if they're feeling that symptoms are really exacerbated, and then prolong that tapering period.